Good afternoon, everyone, and welcome to the Board of Pharmacy's webinar today. I'm Chief Inspector Tom Glinsky, and my guest today is Michael Boger. He's the administrator with the Bureau of Narcotics and Dangerous Drugs. Before I turn it over for Michael to do his program, I'll go through a few introductory slides. If you've never been on our webinars before, you're in listen-only mode. If you have any trouble connecting via the internet, there is a method that you can dial in, and it gives you instructions on your GoToWebinar toolbar there to tell you how to do that. We are offering 1 hour of pharmacy continuing education for this program. You must be officially signed in and logged on to GoToWebinar. If you're in a room with multiple people, you will need to be logged in yourself to the GoToWebinar site. CE will not be issued if you're not logged in. And I'll give more instructions at the end about CE. Our CE is not submitted to the CPE monitor, so please make sure that you save your certificates. We have handouts posted on the board's website. We will make a recording of this and post it on our website in a future date. We'll try to take questions at the end of the program. If you'd like to submit a question to us, please go to your toolbar and you can type the question in and hit send. And again, time permitting, we'll try to answer some of the questions. So now I'm going to turn it over to Mike. Thanks to you for coming today, Mike, to do our program for us.
Thank you very much. Well, we always appreciate being able to come and reach out to everyone and answer some of the questions and look at some of the hot topics that we're dealing with. So I'll just go through these slides here and talk about what we want to cover today. I want to talk about some rules that BNDD is in the process of updating, going through the administrative regulatory process, through our legal counsel, the governor's office. We'd like to get these filed at the Secretary of State's office as soon as possible. Pending legislation that has been passed may be on the governor's desk for signature, what passed this year and what didn't. I want to talk about our overall state opioid abuse reduction efforts, what we've been doing to fight the opioid crisis. I put out an announcement earlier on our website about prescriber signing the prescription the same date it's issued, so we'll talk about that, and then we'll open it up for some questions. We've been drafting on some rules that we are in the process of updating. We're going to update the rules to match what the DEA has already done to bring Missouri in line. The first rule is to allow the partial dispensing of Schedule II drugs. We're going to do exactly the same thing the DEA has done. We have that rule worked up and ready to file. We just need permission to file it with the governor's office. As we'll see here coming up on one of the slides, they passed a Senate Bill 826 that would allow pharmacies to have disposal boxes for patients wanting to drop off unwanted drugs. We're going to have a rule that mirrors the DEA. We're not going to require anything new on that. So pharmacies that want to participate can just follow that DEA guideline, and we're going to go with that. And then we're going to try to get our rule file to update the emergency kits for long-term care. We just want to clarify that and talk about how that's handled to give the nursing home some better guidance. During the past month, there's been a lot of legislation that everyone's been looking at about controlled substances, everything from the opiate issue all the way to preventing problems on the streets, preventing disease, needle exchange programs. This past session, 26 different bills were filed involving controlled substance issues. When we prepared for this seminar, there were 13 that were still moving and going through the process, but they wanted to add the illegal fentanyl to the illegal trafficking statute. We want to allow the collection boxes in pharmacies. They were looking at needle exchange programs. There was a bill to maybe have patients sign a form where they can tell their doctor they're refusing opiates. There was a bill about our Bureau and the Board of Pharmacy being able to work together with some funds for education. There was legislation to track newborns who are born exposed to controlled drugs. They wanted to track them after that to make sure they were getting the care they needed. There was a bill where we would have a database to track drug abusers that doctors could see. A bill was filed to allow safe consumption locations where people on the street could go to abuse drugs and not be bothered by law enforcement. There was a bill filed that would require all prescriptions to be electronic. That would have done away with handwritten prescriptions, telephones, faxes, and it would have forced everything to be electronic. There was a bill filed for our department to conduct a study about foreign drugs and could they be brought in at a lower cost. There was a bill filed to limit first-time prescriptions of opiates to a 7-day supply. And then there were other bills filed, a second bill to allow drug disposal boxes, and then there was a bill filed to update the list of controlled drugs. The overall work to reduce the opiate abuse that was going on has been going on for the last year, and it involves a lot of different state departments and agencies. We've been meeting with the boards, the Board of Pharmacy, Healing Arts. We've been working with Medicaid and MoHealthNet, Department of Mental Health. We've been to Washington, D.C. and gone to a lot of meetings about best practices. And I've kind of got a list up here of things that the federal government said that states should be doing. Have a PDMP, offer more CME hours for prescribing, follow some opiate prescribing guidelines. If you can find a way to license or regulate pain clinics, increase opportunities for treatment, medication-assisted therapy. That would be your Suboxone, buprenorphine, things like that. Putting more education out for patients on how to handle and protect their medicines, take-back programs, disposing of drugs, things like that are all items we've been looking at for the year. So when we came back, we formed this prescription drug misuse work group, and it involved all these different agencies from state government and associations. And as you can see up here, the state departments, the regulatory boards are up there, along with law enforcement, mental health, and our professional associations for pharmacy, the physicians, the dentists, the hospitals, different groups, metropolitan health departments from St. Louis, Kansas City, and others, all coming together to come up with ideas and try to get stuff that we can do. We don't have any state guidelines for the proper prescribing of opiates, but our Bureau took the CDC guidelines, published them on our website, put it out there as strictly a guideline. It's an educational tool that physicians could read and look at. And we always reminded everyone, this is an educational document, it's a guideline. They do not carry the weight of a statute or a rule, and it's not enforced by the Bureau like it's a statute or a rule. Going back and just quickly reviewing and talking about real quick how the legislative year ended, Senate Bill 826 was passed by Senator Sater, who's also a pharmacist, and it's his bill that will allow drop boxes to be in the pharmacies. So we will be doing that as soon as the governor signs it. We'll be doing our emergency rule. His bill also states that new first-time prescriptions for opiates will be limited to a 7-day supply. And they define that initial prescription as a patient who has not had a previous opiate prescription for 5 months. So there's also liability addressed back there for the pharmacy. because we don't have a PDMP, the pharmacist is not going to always know what the patient got or didn't get. So there's some immunity there. As long as the pharmacist is acting in good faith, the doctor is going to prescribe accordingly. The pharmacies will dispense accordingly. But some of the things we've been working on the past year, publicizing, doing a lot of awareness. We've established an opiate dashboard on our department homepage that tracks opiate statistics, education, sharing information, talking about overdose events. We had the governor's executive order impacting all state departments. That was last July, so it's coming up on being 1 year old. In the private sector, we have some chain pharmacies and PBMs that on their own are putting out policies reducing about what they will dispense at one time. They're limiting to 7-day prescriptions. They're having their pharmacists ask a lot more questions to doctors, being more selective in their dispensing. They're asking a lot more questions. And the doctors understand that it's the pharmacies that are doing this. It's not a state law, but it's something that the pharmacists are doing to protect their store and their license. The Board of Pharmacies published information on patients protecting their medications at home, disposing of them, how to guard your medicine. And then as we speak, I don't think all the details are out yet. The Board of Healing Arts has been working on a prescribing course, a seminar with guest speakers coming in. Ongoing efforts, the Department of Mental Health obtained a federal grant. With the MOHOPE project, they're seeking more funds to provide treatment, increase the therapy and treatment. We'd like to increase the number of doctors out there that are providing Suboxone, buprenorphine products with medication-assisted therapy. Our department director, Dr. Randall Williams, is a physician. He was able to sign and issue a statewide standing order that would authorize a pharmacist practicing in Missouri to dispense naloxone. That was signed in 2017. So that is out there. Our department has been looking into and tracking neonatal abstinence syndrome regarding drug-addicted newborns and following up on them with proper treatment and care. Recently, the Department of Health and Senior Services, our Bureau of EMS, obtained a federal grant, the Missouri Opiate Reduction Grant. They're getting $800,000 for 3 years in a row to supply first responders with Narcan and train them on the administration of it. So we already have Narcan on the ambulances. This is going to put it into the hands of law enforcement. It's going to the highway patrol. It's going to the water patrol. It's going to local police and sheriff and jails so that they can have it and be trained to use it when they're on the scene. MoHealthNet and the Medicaid people have gradually implemented harder edits that you've probably noticed on morphine equivalents today, per day. It started out some time ago being at 120 morphine equivalents a day. It went down to 90. Now for some patients, it's approaching 50. They're also doing their ongoing review of opiate prescriptions and sending out letters to prescribers on that. And at the same time, our department has reallocated staff, more resources to our bureau, the BNDD, with additional investigators. We've hired 4 new additional investigators this past year, and we did that without new funding. We just rearranged and moved around pre-existing vacant positions from other places. But the current bill on the governor's desk that could be signed this next week would allow us to have 2 more investigators out there in the state. And we have a couple of different programs we've been doing in the BNDD, and they're not the same, they're totally separate. So I want to draw a distinction between the two. The governor's order telling us to set up and run a PDMP with the information and resources that we have. We're doing that by our existing statute and rules. There's been no new legislation passed at this time. We know St. Louis County has one that has up to 57 different jurisdictions, and that's increasing every day. We signed an agreement with Express Scripts, the PBM, where they are giving us prescription data. But because it's a PBM on the insurance side, it's HIPAA protected. They are not giving us any patient identification at all. We're getting no names, no identifiers, no addresses on patients. But what they are able to give us is the rest of the information on a prescription. They're giving us the prescriptions, the date written, the date dispensed, who the prescriber is, their address, the drug names, so quantities, what pharmacies filled them. And with all of that data, we're able to analyze it and determine prescribing levels. And we can look at the doctor's names, their specialty, their geographic area, what population they serve, and it really throws up some red flag identifiers, people that stand out from their peers, because maybe they're issuing a lot more prescriptions than everybody else, and they're in a very rural area, they're not pain management specialists, and it lets us identify red flags. We're able to send our inspectors out to go look at these red flags and leave everybody else alone. Instead of just knocking on the door and not knowing what we're going to find, this helps us as a tool target our resources better. But this information doesn't have any patient information on it. A totally separate project that we're doing that's different is what we're doing with Medicaid and MoHealthNet. They established what they call their opioid prescription intervention program, their OPI. They started this back in 2012. As the payer of last resort, they are allowed to see everything they pay for. So Medicaid can see office visits, the prescriber, the treatment information, what's prescribed, what's being dispensed. It's all gathered through their claims data. This they are allowed to share because it's already in state government, in a state agency. So we're getting a lot more information from them. However, it's only on those 900,000 people in a year who may receive a Medicaid benefit. So we're getting that information. And the system looks for quality indicators. They're looking for prescribers that are seeing patients that may be doctor shopping. There's multiple pharmacies, multiple doctors. Maybe the system doesn't have logged in pain or a reason why opiates would be prescribed. There's a list of these quality indicators, and the system sends letters to the doctors to let them know, hey, your patient's doing this, why are your patients doing that? They've been sending out these letters since 2012. But the thing they're doing now that's different is they're asking the doctors to respond. Can you tell us why we're pointing this out to you for years and there's been no change? What are you doing to address this or fix it? If they're responding and it makes sense, then we drop them from the list. But if they're not responding, then they'll refer them over to our bureau so we can go pay them a visit. We're asking them for reports. They're giving us reports. We're getting reports on high prescribers, the most MME per day. That again allows us to more efficiently decide who to go inspect, where to spend our time, so that we're not out bothering the doctors who do not need to be bothered. We're still going out doing the same inspection we've always done. We're doing our routine compliance, record keeping, security. We're looking to see if they're triggering bad quality indicators from Medicaid. And then we're looking to see if there's a significant and repetitive habit of going way beyond the CDC guidelines. And if we find that, we're making a referral to the Board of Healing Arts because they may not have any BNDD violations. But if the prescribing looks to be way beyond the normal, it's major red flags, we're bringing that to the board's attention so that the proper board can follow up with it. Here's an example of quality indicators that Medicaid is using when they're looking at physician prescribing. that we would want to see a red flag on. So if a patient's involved in drug treatment and they're getting buprenorphine, we want to make sure they're not getting it from several different physicians. We're looking at how they mix any opiate with benzodiazepines, especially if they're getting the triple cocktail, if they're getting opiates, benzodiazepines, and carisoprodol. We're looking for patients using multiple doctors, multiple pharmacies. We're looking for high-use opiates without any kind of a cancer diagnosis. If they have cancer, palliative care, hospice care, pain management areas we're aware of, we're not looking at those as much. We're really getting a lot of reports on high prescribing, and it's still family practice, plastic surgery, other areas like that that are causing red flags. But they get to see this because they can see the entire patient chart at Medicaid. So sometimes a patient's getting opiates and there's nothing in the chart or a diagnosis that supports chronic pain use. So that's what causes these letters to go out, asking the doctors to respond why or update a chart, and then we'll try to reduce them and get them down. The whole project, there's three things that our department director keeps harping on us. The whole project has three goals. Number one, we want to educate. We want to let everybody know about the opiate crisis, the problems. We want doctors to look at their prescribing levels. It's all about education. That is step one. Step two is we want to reduce all this administrative paperwork. If we can keep them from getting those letters, that would save us a lot of time and trouble. When we started in 2012, they were sending out 2,000 letters every other month. Then it was up to 8,000 letters every other month. So if we can get their names off that list, they've responded, things are good. We want to get out of their hair, quit bothering them, reduce that administrative oversight. That's goal number two. And then goal number three is we are identifying some pill mills, some overprescribing, some criminal activity. And if we can address those and get rid of those, then that's happening also as step three. And what we're telling the doctors and what they're being educated to is if they look at the CDC guidelines, page 16 talks about how they think the prescribing should be done for the treatment of chronic pain. If they're getting opioids for acute care, they should not get it for more than a 7-day supply. Start at the lowest possible dose. Immediate release drugs only. Extended release should be for cancer patients. There needs to be an exit plan. The doctors need to strategize with the patient. We're going to try this, but if you're not getting better in 6 months, we need to have an exit strategy. We just can't keep giving you opiates for years. Patients should be seen at least every 30 days for evaluation. That's a guideline. Have that strategy in place. Be careful when getting up to 50 morphine equivalents a day. Try to avoid increasing to 90. Carefully justify your decision making if you're getting up around 90 morphine equivalents a day. And then watch how they're prescribing opiates and benzodiazepines concurrently whenever possible. These are all the things that are listed in the CDC guideline. And this is kind of what we're looking for, because if we see this consistently, repetitively, that's when we're just letting the Board of Healing Arts know. Our Bureau's authority has not changed. There's no new statutes or regulations. We are still doing what we have always done. We'll go out, we'll do inspections, we make sure people are complying with our laws. But now if we're seeing something significant that's consistently excessive, we're just letting the boards know. So in the last 3 months, we've sent 18 physicians over on referrals to the Board of Healing Arts as of this morning. And the boards will look at that and determine proper prescribing, what's proper therapeutic and clinical care. That is still a board's decision. It's not being decided by the BNDD or the DEA or police. The board will look at that. And just to give you an example, the guidelines talk about being very careful when you're giving a patient 90 morphine equivalents per day. 2 of the referrals I've made in the last week had doctors giving a patient 1,800 morphine equivalents a day, 200 times over what's recommended. So, and the patient's been getting drugs for over a year, and the only diagnosis we could find was chronic pain. Well, that's a symptom, but what's causing it? Well, we couldn't find that in the chart, but that's what we're referring to the board. Are these egregious cases like this? We're not looking for somebody who's traveling 71 miles an hour in a 70-mile-an-hour zone. We're looking for the blatantly careless and imprudent driving type of thing, if you want to compare it to that. Changing topics to the next item on our agenda now, one of the things that we ran into was a lot of prescriptions being written by a doctor. We found out they had opened up 3 locations, and they were seeing 3 times as many patients, issuing 3 times as many prescriptions in 3 separate towns. But the DEA discovered that the doctor would sit in their office and write out hundreds of prescriptions in advance, send them down to the clinics, and then the nurses would hand those out for the whole next week. And the DEA discovered that going on in St. Louis. So they talked to us about publishing a reminder about what the state and federal law says. Let's educate our doctors so that they're not doing that. So we put something out on it. And then within the next week, we found a doctor in Columbia, a doctor in Cape Girardeau, another doctor doing this. We had a case where a pain management clinic was being ran by chiropractors, and they can't prescribe. So they had a plastic surgeon pre-signing hundreds of prescriptions for them, and they would keep them in a drawer, and chiropractors were handing them out as they saw fit during the following weeks. So we put this out that we wanted to remind the doctors what the current laws say and have always said about issuing controlled drug prescriptions. You write and you sign it and you date it the same day it's issued. That means that's the same day it's leaving their hands. So if it's issued, if it goes to the patient or to the pharmacy, they might mail it, they might fax it, it might go electronic, it might walk out the door on a paper prescription. But when they give it to the patient, it's issued. When they get it to the pharmacy, it's issued. If they're mailing it to the pharmacy, it's issued. So give them out that same day. The day is the key word, the date. Our statute says prescriptions are dated on the same day you issue them. The bottom line here is we do not want prescribers writing prescriptions in advance so somebody else can hand them out the rest of the week. That's what we're trying to stop. That's all I have. My contact information is up there. If somebody wants to send me an email or ask a question, if we don't get to your question today that's on our list here, shoot us an email and we'll try to answer those and get back with you in the next week or so.
Okay, we're going to now move on to questions. Just a reminder, if you want to send us a question, go to your GoToWebinar toolbar, type in your question and hit send, and we'll try to answer some of them that we've been receiving. So let's see. Some of these are ones that we get a lot of. So first one is, what constitutes the medical reason for more than a 30-day supply on a C2 prescription? And examples are, they want to know, is diagnosis alone sufficient or LTC patient alone sufficient? What constitutes a sufficient reason?
That statute in Chapter 195 just says the prescriber needs to document a medical reason on the prescription, but they don't define what they want. What we normally see is a diagnosis and the status. That's the 2 things we're seeing. So the number 1 prescription out there written for something like this is normal ADHD drugs, methylphenidate, Ritalin, the stimulants, we normally see them stable ADHD is what's written on the prescription. That lets the pharmacist know what the patient has, their status, that they're stable. The doctor knows their condition. They're seeing the doctor. They're getting the prescription. It has to be written in English, and it cannot be just a diagnosis code number. It's not acceptable. And if for some reason the doctor doesn't write that or provide it, the pharmacist can call them and add it, or if the doctor faxes something, they can attach it. But the diagnosis and the status is the common thing that we're seeing.
Okay, let's see. Next one has to do with prescriptions from nurse practitioners and PAs. When does the physician's name have to be on the prescription label?
Every time on every label. They put it in our labeling statute in section 195, 100.5. It requires that when drugs are prescribed by an APRN or a PA, the collaborating or supervising physician's name gets printed on the label. So they put that in the statute.
And that's just for controlled substances. That statute applies only to controlled substances. It would
Yes.
not apply to non-control. Let's see. When a patient drops off a written prescription, must their address be on the face of the prescription, or can the pharmacy add it by placing a sticker to the back of the piece of paper?
The prescription is what the prescriber writes on the face. And all the laws require that the doctors provide a complete prescription. That's what's written on the face. The sticker that the pharmacy is placing on the back is your dispensing record. So the DEA regulation and the state statute both specifically state the patient's address has to be documented on the prescription. That's on the front face. So the prescription's on the front, but the sticker on the back is the dispensing record. So that's how the statute addresses that.
Someone's asking for some guidance on if you get a C2 prescription that has a patient name address sticker applied to it, so like it's coming from maybe an ER where they attach the sticker to it instead of writing the patient's name or address, what can the pharmacy do on that C2 script? Since it's a C2, do they have to send it back, or could they call and add the name? What's your suggestion for that?
The DEA regulation states that these written prescriptions on paper have to be written or typed, the prescription in ink or indelible pencil. We've talked with the DEA about this. They do not allow stickers. Stickers get peeled off. They can be used on other documents. Sometimes those stickers dry up and fall off, and then we end up with stickers in the bottom of a drawer, and then we end up with prescriptions with no patient name and address on the front of them. The law does not allow for stickers anywhere. They would have to, on those, they can't change or add the name of the name. So they can't add the patient's name. So they would have to be rewritten if it's a Schedule 2.
For a C3 through 5, they could call and turn it into a telephone script. Okay, our next questions deal with prescribing quantity limits for out-of-state mid-level practitioners. So these are nurse practitioners or PAs that reside in other states. And they want to know, does the 30-day C2 limit apply to those prescriptions?
It does not. When it comes time to look at prescriptions from mid-level practitioners, all those restrictions are on Missouri licensed practitioners practicing in Missouri. So it's our nurses, our physician assistants, our assistant physicians, it's our Missouri practitioners that they've restricted to certain schedules, 5-day supply of opiates, no refills. Those restrictions do not apply to prescribers from out of state. So if you're getting prescriptions from our bordering states, Kansas, Arkansas, Oklahoma, or Iowa, those can be dispensed as written. They're prescribing according to what their state law allows. So Missouri pharmacies can dispense according to what those state laws allow.
Okay, this next question, we've been getting a lot of questions about this from pharmacies, and they want to know, can a Missouri pharmacy legally sell OTC, CBD oil, or hemp oil? And the follow-up is, does the percentage of THC in the product make a difference?
In the definition of marijuana, they exempt any product that has less than 0.3% THC. So if it's more than that, it triggers the Schedule I marijuana statutes. If it's less than that, they're considering it a hemp product, which is mainly fibers from the stalks, things from other things that are not included. So there's been new legislation passed about allowing the hemp to make T-shirts and rope and products and things like that. If it's more than 0.3% of THC, it's going to trigger the marijuana statutes. If it's less than that, it will not trigger the statute. We're getting more questions about CBD oil. We have a specific definition of that, how that has to be sold in Missouri, licensed through agriculture. But those questions are mainly all going to the Department of Agriculture, to Mr. Brent Holcroft is in charge of that program that oversees all of the marijuana licensure operations, the CBD oil, and those types of extracts.
So I know pharmacies are getting solicitations to stock this stuff, so you would suggest they contact the Department of Agriculture
Right.
to determine if the product is legal in Missouri.
Right, because they can find out, is the product legal? Do they consider it to be a hemp extract, the CBD, or an illegal marijuana product? Because the Department of Agriculture licenses those manufacturers to make it and dispense it, and what can be sold is done by that department.
This is some clarification. You kind of talked about this. At this present time, can Missouri pharmacies collect old controlled substance prescriptions from patients for destruction?
At this time, as of today, our current statute says that you can take back medications if you originally dispensed them. But collecting medications from other dispensers cannot be done yet. But we hope to see that change this next week. The bill was passed to allow disposal boxes. So as soon as that gets signed, we want to do an emergency rule to get that started.
But they need to keep in mind that they still have to comply with DEA regulations on take back if they're going to do controlled substances, even once our statute gets passed. This one has to do with homeless patients or people who are not living at their home. What should you use as the patient's address if they don't have a home, such as a homeless person or someone living in a shelter?
Right now, the DEA federal law and our current state law, it requires a patient address. And there are no exceptions in that. If there's no known address for the patient, or they don't have one, if it's not possible, if they're truly homeless, we've seen in the past, talking with the DEA, they will use the doctor's clinic address of where the doctor's office is. That way, anybody who comes across that prescription or needs to do follow-up would end up at the doctor's office. They would find out that's where it happened. There would be a patient's chart there. There would be a record there of their care. So we've seen instances where they put down the doctor's office as a patient address.
Let's see. Can a pharmacy deliver a filled controlled substance prescription to a doctor's office for the patient to pick up at the doctor's office?
Retail pharmacies are licensed to dispense prescriptions to patients. If they start delivering drugs to other medical providers, that makes them a distributor. That's distribution. So the best thing to do is to dispense directly to the patient. Don't deliver to another medical provider, doctor, location. That's the first statute. The second statute is it's illegal in the state of Missouri for any prescriber to take back prescriptions of a patient, their medicines that they did not originally dispense. Prescribers, doctors, or mid-levels, they cannot take possession of a patient's unused drugs. It's not legal. We have a lot of problems with doctors writing a prescription for a patient, and they tell the patient, bring it back and give it to me. That's how diversion occurs. So we have a specific statute out there that tells doctors, if you take possession of a patient's medicine, you're in illegal possession. So they should not be accepting these medications from a pharmacy.
Now, we do allow non-controls to be delivered to a doctor's office, so Mike's response was related just to
Controlled substances only.
Next question, when does a pharmacy need to fill out a BNDD loss report?
When a drug is lost, stolen, or a diversion has occurred in your pharmacy. If it's lost and you don't know where it went, you have no idea what happened to it, it's just missing, you would turn it in as a loss report. If you know it was stolen, if you had a burglary, some type of a theft, you would do that. Missouri is different than the DEA because we also require you to report diversion. Diversion could be the drugs aren't lost, you know where they went. Well, they weren't stolen, somebody paid for them, but there was diversion. An example would be we had a pharmacy technician make up false prescriptions, take drugs out of the pharmacy for themselves, but they paid for it so that everything was balanced, the pill counts balanced, everything balanced. When they found out that was going on, it was illegal activity, but they know exactly what happened to the drugs and where they went, so they weren't lost. They weren't stolen, they were paid for, but there was major diversion going on. Well, that has to be reported. So the regulation requires that you notify us immediately on discovery. You can give us a phone call, a fax, an email. Let us know about it when you first discover it. And then after that, you do a loss report. It's due in 7 days. And if you need more time, just ask us. We always grant that.
This one's about partial filling the C2. Do you have to assign a separate prescription number to each separate dispensing? I think they're talking about when you partial fill for a nursing home patient.
The prescription numbers we don't know because we don't get into that. That's not a BNDD DEA issue. But we know that for long-term care and hospice, you can do partial dispensing. So you'll just write down on every event the date, the quantity dispensed, keep track of all those separate partial dispensings. We just want to make sure that you don't go over the total amount authorized and that it all happens inside the 6-month period that the prescription's good for. But assigning a separate prescription number every time is not a BNDD DEA issue.
The next question, I think a doctor has only seen this patient once, but he has been prescribing to the patient for over a year. Is there a limit on how many times a doctor must see a patient or how often?
There's no written law on that. It's going to be a board issue for peer review. We would have to report that prescriber to the state board and let them interview the doctor and subpoena the chart, find out how many times they've seen the patient, but what they're prescribing to them, how often. They'll make a decision of whether or not they think that's appropriate.
This question has to do when a prescriber dies or if they have their BNDD or DEA or maybe their Board of Healing Arts registration revoked. What happens to their, can you continue to dispense their existing prescriptions or refills when that happens?
Yes, as long as the prescriptions were legal and valid at the time they were issued, they're good prescriptions. The prescriber dying just doesn't automatically void all of their prescriptions and orders that are out in a hospital. So you can still honor those prescriptions. The patient will know they're going to have to go find a new prescriber after that.
Okay, the next question deals with, I think you talked about when you're reviewing some of the data you get classifying people as drug abusers in a registry. They want to know what criteria is used. They're concerned people see multiple doctors for valid reasons. Would they be considered to be an abuser?
And we don't have a database for that. And that's one of our issues. One of the legislators filed a bill that would tell us to put all drug abusers in a database. And then we would only watch the drug abusers. Well, we don't know who that is. How do you determine who that is? How do you make that decision? Who puts them in there? Who takes them out? I think that's one of the reasons. That was on the list of bills that did not pass.
Back to data. Someone's asking, you mentioned about the data from Express Scripts. Does it include Medicare, Medicaid, commercial, and is it only data from their client base?
I think it's from the PBM. It's their insurance claims data. It's going to be everything that passes through the claims that they're looking. So I think if it's insurance, if it's cash, that's what we're going to be seeing. If it's Medicaid, we would get that from the Medicaid side, from that database.
Someone wants to know, what is the holdup with the PDMP in Missouri?
Legislation passed by the House and Senate.
And you said that in this year there is no legislation made it through again.
No, they didn't. They filed it. Representative Rader filed the bill early on, and it just did not make it through the logjam, through the committees and onto the floor. It was filed again, but it did not get any traction.
Do you have a suggestion about how to address prescribers who give out simultaneous parisoprolol and other benzos? You ask the doctors, they tell you one's for muscle relaxing, the other one's for anxiety, sleep.
That would be a peer review, clinical review question that you would run by the Board of Healing Arts.
This one wants, have you tracked how much naloxone's been dispensed or given out with the standing order since it went into effect? Do you know?
No, we don't. Not right now. Okay. With the standing order, we don't know. We just know that we're going through it so much that the price has really skyrocketed for those drugs. But right now, we don't have a reporting database to find that.
This one, more questions on chronic pain diagnosis. What additional information would you recommend pharmacy ask in order to fill a 30 or 90-day prescription?
Different pharmacies have asked different questions. The pharmacies may have their own policies, but some of the pharmacies have just made it their own internal. They're only going to dispense 30 days at a time. Is it acute? Is it chronic? Are they going to do extended release for non-cancer? But they kind of follow, I think a lot of them are following the CDC guidelines. They're saying, is this a new patient, new injury, acute care? Should they get 7 days? Are we going to do 30? The pharmacist there can use their judgment, make their own independent decision. Just because the doctor writes it doesn't mean that it has to be dispensed. The pharmacists are going to come up with a lot better questions to ask the doctors than probably the BNDD would. The BNDD inspectors are not doctors or pharmacists, either one.
Another related question. What do you recommend what actions should the pharmacy take when you do have someone over 50 or 90 MME?
We're looking for consistent, routine, high levels. Sometimes you find out that a patient might be on 95 or 100 MME, but then you find out, they're in hospice or there's some other reason, where they're explaining that. And maybe they're on their way down, where they're only on 100 MME for a short period of time, and then they're slowly bringing them down 10% a month. And if you can look back at their history and see that a doctor's trying to taper them, that's okay. But, we're really interested when somebody's been getting 120 MME and it's been going on for months and months and months, and there's no tapering in sight. People can call us, email us, and just say, hey, you might want to look at this doctor. They're prescribing this or this patient. We can come in, do a request for records, look at things. Because normally when we find the doctors doing this, it's not just one patient. We're looking for, it's a routine, multiple patients, high levels all the time is what we're looking for.
Someone's asking, on the referrals you sent to Healing Arts recently, has that board taken any action that you're aware of?
Not that we're aware of. We've only been sending these referrals over maybe this quarter, the last 90 days or so. So the board meets quarterly. I know they're assigning them out. We've had some investigators call asking us for more paperwork or additional information because a case has been assigned to them. But they're beginning their review. I don't think they have finalized an action yet.
This one wants to know, does the MORE grant cover public schools and training for school nurses or lead administrators for Narcan?
It does not cover schools or school employees. The federal grant was strictly for law enforcement first responders.
Can you explain how the new federal law allowing partial fill is different from our current law?
Our current law says that you can partial fill schedules 3, 4, and 5. That's okay. But our current law says that schedule 2 partial fill can only be done for patients in long-term care facilities or hospice. They're the only patients that can get partially filled schedule 2 drugs. That's what our current rule says. We're going to amend it to match the CARA Act that Congress enacted that's going to allow all patients everywhere to get partial filling of schedule 2 drugs. So it won't be limited to just nursing homes and hospice. Now, any patient, if they have a 90-day supply of a schedule 2 drug, but they don't want all 90 at once, they want to come in and partially get a few at a time, this would now allow for that.
And this doesn't change the pharmacy's ability when they're out of stock and they have 72 hours to get the remaining, that still stays the same.
Yes.
Will be the same. So basically it'll allow any patient the option to get a partial amount. Okay, as for clarification, will it still be allowable for a prescriber to issue multiple controlled substance prescriptions as long as they are all written on and signed on the same day?
That is absolutely correct, yes. The date written and the date signed is always what goes at the top of the prescription. The top of the prescription, right up there by the patient's name and address, and the date is today's date, the date written and signed and issued. Now, across the bottom, they can still write, do not fill until July, do not fill until August. They can still put do not fill dates across the bottom.
On limits, can you clarify, Kansas nurse practitioner, are they held to the 5-day limit for a Norco for prescription filled in Missouri?
They are not. Kansas nurses have full authority, so they could write for a 30-day supply.
Seeing a lot of paper scripts that say electronically signed with a type name but no real signature. Are those valid?
No, they are not. If somebody brings you a prescription on paper, it has to be signed in original ink.
And that's just For controls.
For controlled drugs.
Now we do,
Yes.
the board does allow it for non-controls, but it has to be on a, some type of paper with a feature to prevent copying. And that also applies for controlled fax prescriptions. They have to be physically signed to before the doctor faxes them. Is there any plans to increase monitoring of amphetamines and other ADHD medications in addition to opioids?
We would love that. We would like to extend to that. Right now, we're using a lot of our resources and funds and what we're doing on the opiate crisis to save as many lives as possible. But we would love to expand someday out into that. And I think, of course, MoHealthNet already can see it. They can run a report on that because they're the payers. So they can see the doctor visits, when it occurred, the prescriptions, what they're paying for and how. So the Medicaid data would already be doing that. But right now we're focusing on opiates before we get into the other drug classifications.
Is there any regulation on mailing a controlled drug?
Not with our state statutes or regulations. We don't have any statutes or regulations with BNDD that talk about mailing it. You know, just for security, we would want it to be in a nondescript plain package. The dispenser's responsible for it until it's ultimately delivered to the end user. If they say I didn't get it in the mail, it was lost in the mail, whoever mailed it would have to do a loss report. But I'm thinking maybe a lot of the regulations from that might come through the Postal Service.
What is the proper procedure to follow after discovering a fake controlled substance prescription?
I would immediately call the police. That's my personal opinion. If you don't call the police, then you're going to let that person and all their buddies know they can always come back to your pharmacy, pick on you, scam you, bring you false stuff. And if they get caught, nothing's going to happen to them. So if you send a clear message that, or even just put up a sign, if you just put up a sign that says, we check for fraudulent prescriptions, we call law enforcement, they'll stay out of your store. But you know, we hear a lot about that. That happens a lot. The patient shows up and the prescription isn't written right. It's terribly forged. It doesn't make sense. They find out the doctor didn't write it, so they call the police, and the police can be there, come by, take that person into custody. No drugs have to be dispensed. You don't have to dispense anything to them. The statute is triggered. It's a felony when they falsify the document. It's a felony to possess it. It's a felony for them to pass it to you at the pharmacy. So they're guilty just for walking in the door with it. You don't have to dispense anything to them.
Well, we're almost out of time, so we're going to have to stop the questions here. Mike said he would, if you want to email him the questions that we didn't get to, if you want to email him at bndd@health.mo.gov, he would try to get you an answer back for the ones we didn't get to today. I'm going to move on here. Our next, we'll have a Lunch with the Chief webinar in August. We'll give a legislative update. In the fall, we're planning a sterile compounding update, and we also most likely do a pharmacist administration immunization update this fall also. We don't have exact dates yet for any of these. To get your CE, you need to do not close your browser. Once I say I'm going to close the webinar, a little box will show up and it will tell you that I've ended it. You want to click close on that. Still do not close your browser, leave your browser open, and a survey will pop up, a 5-question survey. Answer the questions online and click submit. Should you not get the survey to open up, you can email us at compliance@pr.mo.gov and ask for the questions. We'll send them to you by email, but you must get the answers back to us within 24 hours if you want CE. We will mail out certificates in approximately 30 days, and we will post a recording of this webinar in approximately 30 days. Before I close, I want to thank Mike for coming today. We try to have him every 1 or 2 years come over and give a presentation. We find it very helpful. And based on the number of people who logged on today, we get a high turnout whenever you come, Mike. So interesting topic. So again, thanks for coming. I'm now going to close the webinar.